pathway versus the PTT measures the intrinsic pathway. I say, well, it's a PIT when you bring your pet to work. And the students all roll their eyes. They say, good dad joke. But really, PTT stands for play table tennis, which usually you're playing inside. And then the common pathway is the one that is abnormal both. So where this is important for you guys is that you see if you have a deficiency in fibrinogen factor 1 or prothrombin factor 2 or 5 or 10. That's all in the common pathway. Remember the small denomination paper money. You'll have both abnormal extrinsic pathway or PT, and you'll have normal intrinsic pathway or PTT. So that should be our clue as clinicians that we're looking at something in the common pathway. Or there might be a problem with multiple factors, but versus if it's only the PT that's abnormal, then we know we're looking at a problem with just factor 7. If it's only the PTT that's abnormal, then we're looking at something just in the intrinsic pathway, and then we look at the levels of factors 12, 11, 9, and 8. Okay, so quick orientation to the pattern-based diagnosis. This is a little bit what I mentioned already. Just a PT, we're looking at factor 7 deficiency. Maybe there's vitamin K issues. If it's just prolonged PTT, that could be 11, 8, 9, 12, type 2N von Willebrand, where the factor 8 can't bind to the von Willebrand factor, or some inhibitors, and then both of them prolonged. That's the common pathway 5 factors. Or if you have liver disease and you're not making the factors, or you have DIC or disseminated intravascular coagulation that's kicked off by trauma or an infection or something like that, and you're making factors and you're using them and everything works fine, but you're making these little indiscriminate clots all over your body, and they're getting stuck in your lung and your liver and your spleen and your kidneys, and they're not going to places where you have an ID poke, and so you're oozing at that site. Or vitamin K deficiency, whether you're on vitamin K antagonist like warfarin, or you are not getting enough salads. And I mentioned the mixing study already, so we won't get into that more. So we can look at people's genetic assays and look for problems in known hotspots as sort of a quick look to see if we can identify what's going on. But we may need to do different looking if we may have to sequence the whole gene and look at every amino acid along the way to see that there's not a problem there. The phenotype is what the lab pattern suggests, and that's either a qualitative problem where you make enough protein but it doesn't work well, so the quality of it is not good. Or you have a quantitative problem where you don't make enough of the protein, the quantity is not good, or both. And then how does that fit clinically? And this is where the bleeding risk diverges from the antigen or activity percentages, which is what I think the woman in the middle of the room has been struggling with. I noticing by her reaction. And they say, well, you've got a good number. Yeah, but you haven't checked my other number. That one may not be good. So we won't belabor that point anymore. So I'm just kind of, I skipped through all the animations. So I got ahead of myself just a bit to be able to put all this up because you can review it quickly, but I wanted to kind of summarize that point on one slide, that we need all these different components to figure out, A, is there a problem? B, how bad is the problem? And what might these patients expect? What can we tell them about how things are going to go with menses or childbirth or surgery or playing sports or that sort of thing? So we have to combine all these things together. I think it's a mistake for providers to be overly focused on just the genetic results or just a protein level and activity or an antigen. Uh, when we put names on these things, quantitative deficiencies where you don't have enough protein, that's type 1. Qualitative, where your protein doesn't work, that's type 2. That's a little bit of a trick of the trade, is to put 3 or 5 or 7 names, each with the same thing, and then maybe throw some Roman numerals in. It helps with job security. But I'm trying to lift that curtain a little bit for you guys, so that, I poke fun at it, but I realize it is a barrier too for patients to understand what's going on. And if anybody should understand what's going on with your blood, you should. You have a question over here, but I'm hoping we can get through this, and then we have, I think, an hour for questions later.
I wanted to see the slide before that we took.
The slide before is sort of similar. Oh, really? Yeah. Oh, there we go. Sure. Okay, we'll zip through these, and then, okay. So, at long last, we're getting into the actual deficiencies. So, we got to start somewhere. So we'll start with number 1, factor 1, or fibrinogen deficiencies. There's lots of different flavors of this. So you can have A, fibrinogenemia, which is A is Latin for none. Hypo, which means not enough. Or dys, meaning doesn't work. Or I think like make fun of somebody, usually in a raft track. Anyway, and these can be either autosomal recessive or autosomal dominant. Meaning autosomal recessive means each parent has to have a variant in their gene for their offspring to be affected, versus autosomal dominant, only one parent needs to carry a variant. So bleeding with fibrinogen deficiency can include umbilical stump bleeding, and this I see a lot as a pediatrician. And if you may not remember your own umbilical stump situation, but you may remember that from your children, if it bled a lot when it was supposed to fall off and just sort of heal up. Mucosal bleeding, so that's mucous membranes anywhere in the nose, the mouth, the throat, the stomach, GI tract, reproductive tract. Bleeding in any of those areas is affected. Postpartum is bleeding after delivery. And then interestingly, the dysfibrinogenemia. Okay, so one problem is not enough. You got this bleeding disorder. If you have dysfibrinogenemia and you make an altered fibrinogen protein, in some cases it can work not very well and you bleed. In other cases, it can work too well and you can clot. And some of this happens in the same individual. Like there are groups of fibrinogen deficient patients or conservative dysfibrinogenemia, let's see, patients that bleed, and some that clot, but sometimes it's the same patient that can do one or the other. So like I mentioned earlier, since this is down in the common pathway, both the PT and PTT will belong. It's a factor deficiency, so if I add some plasma off the shelf into your sample, that is going to correct. We can look at the activity, we can look at the antigen, do a ratio to suggest this, and then we can do some genetic evaluation to say, oh yeah, there's the problem. And other people with this variant, this is sort of what's exciting about the advent of genetic diagnosis, is we can say, okay, so you have the same variant that all of these people have, and this one did okay, and this one did okay, and this one had a little bleeding under surgery, but that one did okay. So for the most part, we think you're going to be okay. Now, I spent a couple slides telling you that that's not the whole story, but it gives us a general sense. And how do we make it better? We can give you some normal fibrinogen. So there are concentrates that are made. There's 2 different brands available in the US. Or we can use something called cryoprecipitate, which is when you take plasma, you freeze it a little bit, comes to the top, and we can pull that off. And that's got a lot of fibrinogen in it. But we don't want to give too much and then lead into a clot. So here's these words again: quantitative. Your quantity is suboptimal, so you don't have quite enough. Either you don't have any, that's afibrinogenemia, or hypo, you don't have quite enough. Or we've got qualitative problems where you have enough, but it doesn't work very well. And that's the dysfibrinogenemia, where you have abnormal function, either too much or too little, or both. And then the super exciting one is you can have hypodysfibrinogenemia, which I think should just win you the Scrabble game right there, if you could find a way to get that in. But this is, you have not enough and it doesn't work well, except for when it works too well. So I kind of hit this clinical pearl that not all bleeding disorders are only bleeding disorders either. Even some of the other bleeding disorders, other than fibrinogen, this is the only one that sometimes can cause clotting by itself. We have to be careful as providers, and you have to help advocate for yourself with providers that are not as familiar with these diseases, so that we don't overcorrect your disorder and swing the pendulum the other way and put you at risk for clotting. So fibrinogen is about 1 in 1.5 billion. So that's less than 1 in a million people. So we got, maybe 300 people have some of these inherited fibrinogen disorders in our country. I think I'm not going to spend a lot of time on the exact numbers, but since you're already here at the Rare Bleeding Disorders Conference. Okay, so factor 2. 1 in 2 million, or half a person per million. Males and females, the incidence is equal, as opposed to something like hemophilia A or hemophilia V, where these are X-linked disorders. So people with fewer X chromosomes are disproportionately more affected. Other kinds of providers think a lot. So I think the patients are best served in coordination with a HTC. So there are not a lot of tissue factor deficiencies, just factor 3. Sorry to any calcium lovers out there, we're going to skip factor 4, and we'll get into factor 5. As a preview, we're also going to skip factor 6, which is just activated factor 5, but we didn't find that out till later if you would want to change the numbers. Factor 5 deficiency, another 1 in a million, which is something, your parents tell you, oh, you're 1 in a million. But it says it on a lot of like Valentine's cards that was probably used recently. But here you can literally be 1 in a million, if not less. Again, it's an autosomal recessive disorder, so males and females are equally affected. There's a combined factor 8 and factor 5 variant that is more prevalent in the Middle East. Mucosal bleeding, perioperative bleeding, which means around the surgery or during or after. And the variability in the levels makes it a little bit hard, because you could have one level that's relatively low but not bleed that much, and another person could have a level that's a little bit higher and they bleed a lot. So there's some other kind of modulating factor besides just the factor level that we haven't discovered yet, but that's work is going on there. Again, common pathway, $1, $2, $5, and $10 bills. We're both going to be abnormal in the PT and PDT. It corrects on mixing because you're adding factor 5 back, and then we run that panel of common factor assays, and we see a low factor activity. So there is no specific factor 5 concentrate. So to treat this, we have to give fresh frozen plasma, because that's had all the factors in it. Or, interestingly, platelets have kind of a outsized amount of factor 5. So we can give platelets and they'll go to an area of bleeding after trauma or surgery, and they'll release a bunch of factor 5 right there. Or we use some of these antifibrinolytics to help you hang on to whatever clot you may have. Moving on up in numerical order. Factor 7. I think this is probably, as I understand it, our best represented rare bleeding disorder in the room. It's the most common rare bleeding disorder. I probably should put the quotes around common. So this is 1 in 300,000 or 1 in 500,000 So we're looking at maybe around 6, 7, 800 people in the U.S. with factor VII deficiencies. Again, autosomal recessive inheritance, meaning both parents need to provide a copy, and therefore it affects males and females equally. This is another one where the level does not necessarily correlate to how much bleeding there is. It can vary quite a bit. And so we unfortunately have to spend some time with each patient to see what their bleeding experience is going to be. But levels over 20% usually I don't replace before someone goes to have a surgery. And that goes well as long as that's not the only one. So we have a sense, at least for this disorder, since it's relatively common among rare bleeding disorders, we have more experience with it, and we can kind of tell that those patients are going to bleed less. Like you're seeing, a lot of these rare bleeding disorders are affecting mucous membrane, surgical bleeding, neonatal intracranial hemorrhage risk, but less joint bleeding than in hemophilia A or B. So this is the first one we've talked about more in depth that has only an isolated prolonged PT. The PTT is normal. So when you see that pattern, that makes me think of factor VII. So we check that level and confirm. I've talked briefly before about how genotype trumping the activity percentage, and that has to do with the fact that the activity assays can disagree. So we can do a one-stage assay where we take the blood, we add one reagent to it, and then we look at the reaction. This molecule with a color on it binds to factor VII, and then we can look at how much that is. So that's a one-stage assay. There are two-stage or chromogenic assays. Chromo means color, gen means to make. That's why we have fibrinogen, because it makes fiber. The gen makes plasmid. Chromogen makes color. So here you have to first activate the factor and then add the color to it to see. So it implies a little bit more steps. But the activity does not necessarily account for how much is being made in the liver or cleared in the liver, that sort of thing. So we can have the type 2 defects that I mentioned before, the qualitative defects where the antigen levels or protein levels are near normal, but the activity is low, and maybe the bleeding is out of proportion to the activity. So usually I start by doing the activity, check a couple different ways so we're really sure. Then I look at the protein level, then I do the gene testing, especially if something doesn't fit with the symptoms or what the family is, then spirits it. And yeah. Okay. So we can do recombinant factor VII levels, or we can give a factor VII concentrate for bleeding or surgical coverage. We can use this fibrinolytic therapy, and then we ask our dental and surgical colleagues to do some topical things too, using extra sutures or a fibrin glue or things like that. Depending on severity of bleeding, we may try to prepare more for either infants who are going to get with circumcision or immunizations, or women who are going to have periods or deliver or that sort of thing. Access and practicalities for this, making sure that patients with factor VII deficiency, as well as the other bleeding disorders, know what their diagnosis is, have an emergency plan, have that written down so they can share it with other providers. Like Bree says there earlier, there are a lot of options for navigating insurance and prior authorization. Getting this all documented and shared with other providers is helpful. Just a brief word on rebalancing agents. We're not quite there yet. So in hemophilia, you're missing factor VIII, we can give you factor VIII concentrates. You're missing factor IX, we can give you factor IX concentrates. Some of these factors we have replacement for, but not enough. Um, some of them don't have factor replacements. So there's the idea of rebalancing agents. What if we don't give you a specific factor? What if we just decrease some of the other measures, that other proteins that lead to clot? And can we emphasize those instead? Fituzaran is one that knocks down antithrombin. Benzimab and marstacimab block the tissue factor pathway inhibitor. I think I'm not going to spend a lot of time on these, so we can talk about more things that are relevant. But this is a question that comes up. These are in clinical trials or in clinical use for hemophilia, but there's no evidence to support that they could work in factor 7 deficiency. But I think it's an interesting question that we're looking at along the lines. The nice thing is that some of these medications can be given subcutaneously. So you would pinch a little area of fat, or for me, maybe a big area, and then you can just zip it in right under the skin. You don't have to hunt around for a vein. And they can be given less often. Like factor 7 is a very short half-life, so you need to redose it every 2 or 3 or 4 hours. Whereas some of these medications you can give once a month. So factor 10 deficiency, 1 in about 1 million or 500,000 males and females, both affected, autosomal recessive. Bleeding in the umbilical stump or central nervous system. This is part of the common pathway, so both PT and PTT are affected, and then we verify with a low factor 10 activity. In the US, there is a plasma-derived factor 10 concentrate that can be used for routine prophylaxis or on-demand treatment or perioperative management. We can use some of the other things if we need to. Factor 11 deficiency, the kind of Jeopardy question or trivia thing here is that this is called hemophilia C. 1 in 1 million people, particularly in the Ashkenazi Jewish community, males and females both affected, autosomal recessive. Typically, these patients, I think I mentioned, are not bleeding spontaneously, usually from surgery or trauma. There's not a factor 11 concentrate that's approved in the US. There is in Europe, but not here. So we treat usually with antifibrinolytics to help prolong the life of a clot, or use plasma that has factor 11 in it. 12, I included, but it's not really bleeding disorder. It's one that comes up a lot. And then factor 13, I know we have, factor 12 is allegedly 1 in 1 million, but we honestly come up with 1 or 2 every week. No, it's a selected population, and we're testing people that already have long PTTs, but this is not something that we follow up when we see. And then factor 13 deficiency. So this is the one, the tricky one here is that it's not picked up by a PT or PTT. Because all those measure is until you get the fibrin strips. And then remember I said factor 13 comes in and crosshatches it, but that's after the PT and PTT are already done. So you will never know if someone has a factor 13 deficiency if you're doing these routine clotting tests. PT, PTT, they're normal. These patients bleed from their umbilical stump, classically inside the skull. These are bad places to bleed. So we've got to think not only outside the box, but outside that clotting cascade. We have to do a clot solubility test instead. And there are factor 13 levels, but and we can get plasma. So now jumping outside of the clotting factors, getting into plasminogen. I mentioned these already. Coagulation is making clot. Fibrinolysis is breaking down the clot. Plasmin is sort of the scissors that cuts through this. Get down too fast. These are, and you make fibrin deposits elsewhere, in the eye, your airway, in your genital urinary tract. And this is sometimes how these patients are diagnosed. So again, about 1 in 1 million. Here, males are affected less often than females, but still autosomal recessive inheritance. We talked about where some of these lesions are. Here's another one where the standard screening tests of PT and PTT are abnormal, and you have to be able to think outside of that box. Look at is the problem not with making a clot, but with bringing it down too quickly? And we can look at activity and antigen of those. With the plasminogen protein, we confirm with genetics. Like the other disorders, we've got a type 1 that's quantitative, a type 2 that's qualitative, and we can confirm with genetics. And we want to try to balance these this abnormal clot breakdown out. There is human plasminogen replacement that can be used topically or systemically. Even if you cut out these fibrinogens, ligneous means woody, there's like this kind of consistency of these lesions. They'll come back unless you are restoring normal fibrinolysis. And we try not to give antifibrinolytics because they can worsen the persistence of the lesion unless it's really needed for specific heavy period bleeding or that sort of thing. Usually there's a multidisciplinary team that's involved, and the highlights are involvement of ophthalmology because the eyes are so frequently affected, airway vigilance and emergency planning. Usually we might take a look down there before having a surgery that might affect the airway, using letters for school. So that's sort of a rundown of various clotting factor deficiencies and fibrinolysis defects or plasminogen deficiency. I want to step into just a little bit from the survey I did in conjunction with Kedria, hereditary factor 10 deficiency in America. So we sent a survey out to patients and caregivers trying to get at some patient-reported outcomes, which is the way bleeding disorders clinical research is moving to look at what's important to you guys, not necessarily what I think is important. So we got 30 patients, 38 caregivers in these years, 2021 and 2022. And we focused on their diagnosis experience, their treatment pattern, bleeding frequency, their quality of life, and the impact on the caregivers. About a quarter of patients and caregivers thought that their diagnostic process was somewhat or very difficult. Now, again, this is for factor 10 deficient patients specifically, but I think that people with other bleeding disorders in this room will see that a lot of this resonates. About half of them were receiving the single factor replacement product that is recommended by MASAC, the kind of guidelines committee for rare bleeding disorders. About 3/4 of patients reported using regular factor replacement to prevent bleeding, and a quarter of them had treated with just fresh frozen plasma, which has all the factors in it. So the bottom line is that this affects patients. Optimal therapy has inconsistent access. Ideally, we would be just replacing what they're missing, but that's only half of the patients that are receiving that. Diagnostic delays happen in even specialty disorders. As I said, there are some of these where the standard screening tests are normal, but you have to be able to think about that. I said about a quarter of the patients and caregivers thought the diagnostic process was difficult, and I get the sense from probably people here that that's the case here. Because clinicians are unfamiliar or there's decreased access to specialized coag labs, mild cases are being overlooked. So it's important to refer early to the HTC. Historically, we were treating with plasma, prothrombin complex concentrates, and supportive therapy like oral contraceptive pills, or even blood transfusions. Now we have a factor 10 concentrate, but again, only half people are using that. Quarter of people are using plasma, and then a quarter of people are using some other sort of therapy. So anticipating ahead of time. This gets back to the advocacy piece that Bree was talking about earlier, getting prior auths lined up, making sure that your local hospital has your factor 10 in stock. Or I heard someone else was talking about this with the factor 7 product, to make sure that your local hospital has them. Or if not, you have it and you bring it with you when you go in. I think I'll, for the sake of time, move more quickly through some of these. The idea was that people were bleeding more often when not using the specific factor replacement for the factor they were missing. But we think that we should be able to get towards zero bleeds in other factor deficiencies, as is the goal in hemophilia. Prophylaxis versus on demand. We said about 3/4 of the factor 10 deficiency patients were being treated to prevent bleeding, and that helped improve their quality of life. But there are some of these patients that are having upwards of 20, 30 bleeds needing treatment every year. And when we see that in hemophilia, well, we don't really see that in hemophilia because we say, more than 3, 4, 5 bleeds a year is usually too much. And if that's not the case, then we are changing your drug or your dose or your dosing frequency. So I'm trying to raise this awareness with my provider colleagues to say that just because it's not hemophilia, doesn't mean that they should be bleeding more. We can do these sorts of things too. The bleeding burden was substantial. Sometimes, like I said, up more than 12 per year, up to 36 times a year in one of our cases. Quality of life was affected by bleeding, school, work, recreation, all of those needing to take time off to infuse or recover, emotional strain, and patients reported lower overall well-being than the general population on a standardized tool. And it also affected the caregivers. We took a hemophilia caregiver impact tool and modified it for use here, and there was a moderate impact of burden on the caregivers, but a positive emotion score, which I thought was really interesting. So they said, yes, it's a big burden taking care of somebody with a bleeding disorder, but in the end, I feel good about it. So families go through a lot of stress, but they also build resilience, and that may resonate with people in this room. If we can find a way to support caregivers and patients, then the patients have better outcomes. Since we just went through this in the last 2 minutes, I spend a lot of time on the review. I'd rather take an extra minute on the lessons from these data. Earlier diagnosis usually leads to fewer complications. Factor-specific replacement, to the degree that it's available for your specific disorder, leads to better bleed control. Preventative therapy reduces frequency and severity and sometimes the anxiety of people related to their bleeding. It's important to educate caregivers and patients because they may encounter healthcare providers that are not educated about these disorders. And emphasizes to us and to you guys and to programs like CHEST the importance of data registry, so we can get a sense of who's out there and what kind of complications are they experiencing and what treatments are working well versus not for them. Moving on to some more practical things. I talked about menorrhagia a little bit at the beginning, so I won't spend as much time on that now, but we got a plan for pregnancy delivery. Thinking about dysfibrous anemia specifically, there's risk for thrombosis there. A playbook for perioperative and dental therapy, making sure we know what someone's baseline severity is and their factor level, what kind of procedure they're going to have. We have lots of options there, but having good, we can make a good plan, but sometimes plans go sideways and then we have to have a backup plan. So having the family make sure they know the number to call for the after hours service or to get someone on call. This is the after hours dead tendency. It's at 2:30, which is the dentist's favorite time of day. Right. Hurdy. hopefully most of you have something like this already, an emergency plan that has your diagnosis and your contact information, treatment plan for minor bleeds, major bleeds, head injuries, who to call, what project should or what conduct should be at your local hospitals, or if not, then in your fridge for you to bring to the hospital, medication lists, and then a medical ID, school letters, that sort of thing. There are not kids in this room, but I saw a bunch of them running around earlier and thinking about specific items for them. Umbilical stump bleeding, immunizations, holding pressure for periods after that, not just letting them develop a hematoma. They're planning out a circumcision, head injury precautions, because they're, the toddlers are top heavy like a lollipop, go down pretty easily, and then head always finds a corner of something. Individual safety plans, what to do for gym, PE, that sort of thing. Just like Bria was saying, talk with your coaches, but also here we can talk about with your PE teacher. Travel kits, so if you're going to go on vacation, have you identified a hospital in the area for backup plans? Do you have your factor with you, or is it already there? Rehabilitation joint health for those that have joint problems. The National Bleeding Disorders Foundation has something called Play It Safe or Playing It Safe, a resource that goes through by color. Red activities like wrestling or boxing are more dangerous, whereas green activities like swimming and golf are a little bit less problematic. Working with PT to build muscles, which is, not only do they look great, but they help protect our joints. And mental health is a big component that we also. This is just a screenshot of the Playing It Safe thing, and it lists each activity here along the left. It kind of shows you the relative degrees of safety for each of it. So putting it all together, I think I'll just go through these real quickly in the last 2 minutes. Is just a summary of the factors that we already spent a little bit more time on. The role of the Hemophilia Treatment Center gives you access to that multidisciplinary care model. Social workers, dentists, genetic counselors, those are people who can really help you advocate. Strategies for improvement. I couldn't decide which bit of clip are like better here, so I put a few of them. But education, enhancing awareness, expanding access to factor concentrates. That's what we're working with our pharmaceutical partners on. Supporting testing for at-risk infants if we know their parents have something that could be transmitted, and then encouraging participation in registries and studies so we can get a sense of what's out there. Strengthening relationships between providers and patients too, so that I feel comfortable asking whatever questions, you feel comfortable telling me what I need to know. This I don't need to inform the group here about real much because you guys live this every day, but you have challenges of trying to balance safety in a normal life. The importance of staying active to protect your joints and protect the rest of your health, managing school and work, leveraging your community and peer resources, and considering advocacy not only for yourself but and for others at a higher level, federal, state, local, community level. Chess is a great option for that, connecting families and clinicians, and the community aspect of chess is really excellent. And I won't spend a lot of time on that because you're here with chess, so you know about that one. Athen, Dr. Singleton's going to talk about tomorrow morning. The focus on patients. This is the American Thrombosis and Hemostasis Network, the main registry we have for looking at these sorts of things. So you can track your bleeding in conjunction with your HTC, which helps your HTC, helps your provider, helps us look at large pictures of this to try to decide what treatments are working well and see what real world outcomes are like. And I think I'll defer a lot of this to Dr. Singleton to talk more about Athen, but I think it's an important question to ask. If you're enrolled in the Athen registry, review that with your provider. You can say, can I review my Athen data alongside my labs and bleeding history? That's how you advocate for yourself and see how your bleeding is in relation to other people with this disorder, and is there something that needs to be changed? We've talked a bit about how your factor percentage is not the end of the story. Um, the emphasis on both activity and antigen level. Um, and are we doing, and this is something I ask my patients at every visit, are you on the right medicine or at the right dose and the right dosing frequency? Here's how much bleeding I have heard you have. Is that match with you? How does that feel? And key takeaways. My second last slide here. Rare does not mean insignificant. The impact is profound. Diagnostic delays and treatment gaps persist. Prevention and proper therapy can go a long way towards improving quality of life. But you're not alone. You've got your family, you've got your community that includes your your peers with bleeding disorders, your HTC, your healthcare providers, your advocates. But we all got to work together to do that. Um, these are things you're already familiar with. One, highlight chess. And maybe to start some things for our next session after the break, think about what challenges in your own experience. I showed you a little snapshot of what the factor 10 deficiency patients went through, but what either resonates or doesn't with your own experience. And now it's my turn to learn from you. How can I be a better bleeding disorders doctor and help people in your situation? Yeah.
So before we get to the first question, I just, because there were some questions already about the plasminogen uh, activator inhibitor deficiency, and that's a lot of back and forth double negatives, which my mother told me not to use growing up. But I wished I'd put this in my slide, and then we wouldn't have to take time now to do it. But this picture sticks in my mind because it's a little ridiculous and I'm a little jealous. Um, this is Desiree Collin, who is a researcher published in a real high profile journal, ATVB, the Arterial Sclerosis, Thrombosis, and Vascular Biology. And it's got a big impact factor, and lots of clinicians and scientists read this journal, and it's real fancy and well regarded. But yet they published a nicely done article, but with this drawing in it, which sort of strikes me because like we spend a lot of time in my lab making the figures or the graphs or this sort of thing and tinkering with the font to make sure it's the right size and that this is the right shade of orange and it's not going to clash with this sort of thing. But I could have just hand drawn this little like chicken alligator and done it. And this was in 2009. I thought, well, this is a study from the 60s or something when you could get anything published. But no, 2009. Anyway, but it is pretty elegant. So um, plasminogen, yeah, plasminogen is what turns into plasmin. And plasmin is sort of the scissors that chews up the um, uh, clot. So plasminogen activator is like a little knife. And then plasminogen is this creature, they call it, with a little ring around its beak or its mouth or whatever that is. So the plasminogen activator cuts the little ring off of that beak. And so now it's able to chomp as plasmin. So when they both land on fibrin, which is what the clot's made out of, remember these fibers from your shirt, they're up and down fibers and then cross-linked with factor 13. So plasminogen will bind to the fibrin, factor 1, if you're not deficient. So, no, at least somebody is. And if plasminogen activator binds close by, then the knife cuts the ring, then this turns from plasminogen to plasmin when it takes the ring off and it starts chewing on the fibrin and then you bleed. So here's plasminogen activator, the little knife. That's like TPA, tissue type plasminogen activator. That's what we inject into people who are having a stroke and we want to get a clot gone right away. You can give that. So plasminogen activator inhibitor then is like a little sheath you would put on the knife. So it can't cut the ring and free the creature to chew the fibrin. So if you are doing a lot of plasminogen activator inhibiting, you're not breaking down clots. So people with high Pi1 levels are the patients I see for blood clots because they have not enough clot breakdown. But then if you have plasminogen activator inhibitor deficiency, you don't have enough. So now your knife not only doesn't have the sheath on, but it's like extra sharp, or there's two blades or something. So it's just cutting this all off and turning plasminogen into plasmin, and that's letting that creature chew up the fibrin just as fast. So that's a lot of roundabout inhibition of a negative thing with a deficiency. So I wanted to put this up there just to get us all oriented. So we had a few questions already about some genetic tests results, and based on these tests, do I need to keep looking? Do I need to, but what questions do other people have? I see one up here at my 2 o'clock, and then there's one in the back we can maybe queue up next.
Hi, we already spoke, but I have another question, a kind of a follow-up. We spoke a little bit about comorbid recessive diseases and whether they're genetic accidents or if there's a rhyme or reason to evolution and causing those. But I'm wondering if undiagnosed or underdiagnosed people with bleeding disorders have a propensity to become to have dementia in old age because of brain bleeds. And I say that because my father died of tiny little brain bleeds, and we wondered if he had a bleeding disorder that we were not aware of, that he may have had his whole life, and that probably caused his brain disorders in old age. Just wondering what your thoughts on
Yeah, thank
on
you
that.
for that question, asking about the connection between potentially undiagnosed or underdiagnosed bleeding disorder and dementia later in life due to potentially cumulative effect of lots of small bleeds. And I think the short answer is that, bless you, that's certainly a possibility. It's a little hard to tease out what might be from a bleeding disorder versus what might be from some other kind of vascular dementia where it's not necessarily a blood problem, but the blood vessels themselves start to deteriorate in older age, and there's little bleeding leaks in different places. And the whole problem with bleeding with the brain, well, there's two problems. One is if you have one big bleed, then if I get a big bleed in my hand, the skin will stretch and I can just get a big whopper of a goose egg, and it eventually go down and the blood breaks down and get reabsorbed. But that can't happen in the head because the skull doesn't expand like that. So unfortunately, the only way, if there's a big bleed happening on this side of the head, the only way for that to expand is in, and that pushes the brain down through the hole in the bottom of the skull, which can be quite devastating. But then the other problem is that if there are lots of little bleeds, oxygen that's in the blood is not getting to the area of the brain that should be getting oxygen from that little blood vessel. In this part, the blood is coming out upstream and is not getting to this part of the brain, and the blood is coming out of the vessel upstream and is not getting to this part of the brain. So you can have these little punctate or point-like hemorrhages, and then globally the brain loses oxygen that it needs to do its work. So that's certainly a possibility, and having a bleeding disorder might have made something that was already happening a little worse made it happen a little bit faster. Like, because we all are having tiny little tears in our blood vessels all the time, just from moving around and bumping into stuff. And a lot of you may not notice it unless you're here because you have a rare bleeding disorder, and then that bleed doesn't stop quite as much. So it might have accelerated or worsened a pre-existing problem. And then that could manifest as dementia. It's also possible he had two different things, but it could have happened. Yeah. But I think that's a good way to think about it. Yeah. How about in the back?
So you had mentioned trough levels being monitored. How often should that be done?
Thank you for the question about how often should we measure trough levels? And just to make sure we're all on the same page, we can talk about peak levels after infusion of a factor. Usually within about 30 minutes, you ought to get to a peak level. And this means with this much medicine in you for your body size, different from you for your body size, or you with your body size and age and metabolism, working with children, they metabolize everything faster. French fries, clotting factor, concentrates. So they will burn through something a lot faster. So their peak might be just as high as an adult who metabolizes slower, but then it will drop down. I should go this way so it's the right way for you guys. It might drop down faster because they metabolize it faster versus someone who metabolizes slower is going to have their level drop slower over time along this x-axis. And I think a direct answer to that question is hard to say without knowing what factor deficiency we're talking about. But the idea is you would measure the peak to make sure that this dose of this medication in this person at this time gets to a satisfactory level that will be protective before heading into a surgery or is sufficient to help stop bleeding after some trauma. And then based on what factor, we're talking about factor 7 has the shortest half-life of about 2 or 3 hours. And when I say half-life, that means you get up to your peak, and then how long is it until half of that is gone? For factor 7, that's 2 or 3 hours. So another 2 or 3 hours later, half of that is gone. You're down to a quarter of what you started with. And then half of that is gone. So now you're down to an eighth of what you started with, and it's only been 12 hours. Versus something like factor 13 or factor 11 or factor 10 has a 30-hour half-life. So you can dose that once a week, for example. So the trough then refers to what is the lowest point right before you're about to infuse again. And based on what someone's bleeding history is like, we can say we want your trough level, again, depending a little bit on which factor it is, we want your trough level to be at approximately either this level based on a number, or we want your bleeding controlled. So by some other metric, we want you to have fewer than 3 nosebleeds a day, or we want your periods to stop in 7 to 10 days instead of 25 days, or whatever metric we're using. And then so looking at what the trough level is there, we can decide whether you're getting enough factor or not. So that was sort of a long, rambly answer to try to cover a lot of aspects of it. I think a more direct answer is that I like to check at least one peak and one trough level based off of kind of calculated off of a patient's age and what the half-life is supposed to be for that product to check and see, do we still have a meaningful factor level at what should be the case, and then we decide their dose. But I think you should get your trough level checked more often if you're having more bleeding than you or your provider thinks is worthwhile or appropriate, I should say, or for factors that may change with age. So sometimes people's factor 8 levels go up as they get older, or von Willebrand factor levels go up as you get older in most cases. But a lot of the rare bleeding disorders that we're talking about, those factor levels don't go up. So I feel like that was sort of not a real satisfactory answer. We can talk more specifically later if you want to talk what specific factor level it is, and I may be able to answer better. But those are some of the things that I think about in general when I'm thinking about trough levels.
Dr. Oh, sorry, that's loud. Dr. Branchford, I have a question
Yeah.
remotely. The question says, does the plasminogen factor in Novo 7 work slower in a 74-year-old severe factor 7 patient?
I'm not exactly clear what is meant by the plasminogen factor in factor 7, but in Novo 7, because Novo 7 should be just a recombinant human activated factor 7 molecule, but there's probably, like I said, neonates and babies and young children have the fastest half-lives, and then sort of as you get into early adulthood and middle adulthood, that starts to slow down a little bit, the metabolism. And then in a 74-year-old, the activity will depend a little bit on kidney function and liver function, how these drugs are being metabolized. But I think in general, we're talking about half-life of 3 or 4 hours in someone like that, which is what is appealing about other types of things. So there's been introduction to the market of not only Novo 7 now, but then there's 7-Fact as another brand that does not have a substantially longer half-life, but I think there are factor 7 concentrates in development that have half-lives that are longer, like 6-8 hours, like that. So you might be able to infuse 2 times a day for good coverage rather than 4 times a day. Or that's where I started mentioning some of these rebalancing agents where we're not necessarily trying to increase the factor 7 level, but we're trying to decrease the level of tissue factor inhibition, for example, by removing, we're not giving the car more gas, but we're easing up on the brakes a little bit. So we're still moving forward towards making a clot.
Thank you. I
You're
have
welcome.
another question that came up. For a patient with multiple factor deficiencies, how would you go about measuring their peaks and troughs?
The more factor deficiencies does add complexities, but I think it probably depends a little bit on which factor level is either the lowest, like if some are a little bit below the laboratory range of normals, but there's only one that's in the likely bleeding symptoms range, then I would focus on that one. Otherwise, I would try to say we'll measure as many as we can. There are some that like factor 7 that have a real short half-life. And then there's another group, there's probably like 4 groups across the spectrum, and we could try to group them depending on what exactly the different factor deficiencies are. It depends a little bit on why we're trying to check. Are we just making sure, are we trying to make the diagnosis? Are we trying to treat for a bleed from a trauma, or are we trying to prevent bleeding during a surgery? So that plays a role in it as well. The other thing, and I work with kids a lot who are usually a little low on the enthusiasm for blood draws. So what I try to do is backfill some of the information. So this time we will get what should be a trough level for factor 7. But we know that the factor 11 will still be in their system from the plasma infusion they got. And so that won't be quite a trough. And the next time we do it, we'll shoot more for a trough of factor 11, knowing that the factor 7 is probably going to be totally gone and may even have been redosed in the meantime. And but then we can fill those in. So it doesn't have to be there. We're developing more software programs that you can say, my factor level at X hours after my infusion was Y on a few different occasions, and it doesn't have to be exactly peaks and troughs anymore. Artificial intelligence is enhancing our ability to kind of back calculate what someone's trough would be. We can do higher level projections than I can with my compass and my abacus and that sort of thing. So there are more programs where we could put in random time points to get a suggestion of what a trough would be. Is a way to do that if you don't have just one factor you're measuring. How about in the middle here?
I have a two-part question.
Okay.
I wanted to draw attention to something you said about factor 7.
Okay.
I am in that very rare group of factor 7 where my partner does not have any kind of mutation on his 7. It's all me. And we
Okay.
have 2 children. Our daughter is not affected at all. Perfect cascade. Same with my husband. But my son and I are severe 7.
Okay.
So it's not necessarily true that you have to have a carrier and someone with it to be able to pass it on to your children. But my question
I see.
is,
Okay, I see. Yeah, thank you for that
yes.
clarification.
So I have a question. I have 3 bleeding disorders, 5, 7, and 13, but I was recently diagnosed with hypermobility Ehlers-Danlos syndrome.
Yeah.
So my hematologist now says that physical therapy is the only way to cure me. I have no factor 7 access anymore because he says that all of my internal bleeding, my joint bleeds, all of it is affected by the hypermobility. Would you agree with that?
My first instinct is probably not. Which type of Ehlers-Danlos? There's,
That's all.
which I think is type 3, because there's a type 4 that is vascular type, and that's a little bit more associated typically with bleeding. Because the blood vessels are a little less robust and more easily tear. But there is also association. We'll get together later and I can show you the article that came out in the journal Blood just this week, looking specifically at platelet function disorder in patients with connective tissue disorders like Ehlers-Danlos. So there might be even more about that. So yes, you have the hypermobility, which on one hand means if you get twisted a little bit in some accident, you're maybe less likely to, if I hyperextend my knee, I'll tear some ligaments and have some bleeding. Maybe if you have hyperextendability, you can hyperextend your knee a little bit and then it goes back to where it's supposed to. But that also means it's harder for your joints and ligaments and muscles to get strong and protect those joints because the blood vessels will only bend and stretch so far. So just the mechanics of your bendability puts you at risk for bleeding. But also it does seem like there is a signal in the literature that there's a platelet function defect that's associated with that as well. We'll talk more about that, but I think it sounds like you're in an unfortunate position of having multiple things. Like you have the Ehlers-Danlos, but I don't think that negates having 5, 7, and 13 deficiencies. Yeah, and there's not a product that contains all those things. So I think treatment with plasma that does have all of those, except it doesn't have very much 13 in fresh frozen plasma, which is why we have to use cryoprecipitate instead, or a factor 13 concentrate. Yeah, there's not kind of a one good single factor for all of those deficiencies. And then adding in the case that your blood vessels are not as sturdy or robust as they should be, makes it real complicated. And to me, which I don't need to tell you, I'm sure, your lived experience probably shows that. But I would say that that means we need to think wider. What are all of the things that she, being you, need to have for, say, this surgery that's going to come up? We need to be able to manage the 5 and the 7. We do that with plasma, probably. We need to be able to manage the 13. And then we have to have, bless you, probably a structured physical therapy program that's going to target this specifically, knowing that we need to do it a little bit differently because there is a hyper extendability or hypermobility type of connective tissue disorder too. So I think we need to think wider and step back and say, here is a whole person with bleeding problems across the spectrum. And it sounds like your provider's taken the opposite tact of how can we condense this all into one problem? And it sounds like maybe have somebody else deal with that problem, which is a little discouraging. So I'm sorry about that. But that's how I think about it when I hear about multiple problems within the blood and the blood vessels too.
I have a question.
What's that?
You had mentioned that the rare factor disorders, their levels kind of stay about the same. Every time they've drawn my daughter's factor 10 level, it's different. So she could go anywhere from 35 to 50. She could be 50 today, but then they draw her in about a week from now and she's down in the low 30s. Why would that be happening?
I think that is probably, and thank you for that question, which I should use to clarify my previous statement. I'm thinking about levels of, in particular, von Willebrand, fibrinogen, and what was the one I didn't say yet? Factor 8. That might be real low in a child, and then they go up a few percent each decade and might creep into the normal range by late in life. They're not bouncing around real crazily, but I think probably what is happening with your daughter is that her real level is probably somewhere in the middle, in the 40s, and these tests that are developed in a lab but performed by humans or robots designed by humans, there is some error. And so I think 30 to 50 sort of falls within the range of error for those sorts of tests. If one time it's 5 and the other time it's 80 and then it's 39, I would think about maybe finding a different lab. I would think about what we call pre-analytic variables, which is we draw the blood and then someone drops the tube on the floor and it rolls a little bit before they can grab it. And that agitation can start unrolling the von Willebrand factor through shear forces, or can activate some of the platelets to release some factor 5 and you start clotting. Or maybe it sits on the tabletop too long before it goes in the machine and the protein starts to degrade being outside the body. So there are things like that that can happen that can usually lower the levels. So if one time it was drawn under ideal circumstances and one under less ideal circumstances, or if it's a traumatic draw, we're poking around and then we try the other side and then we try that can do it too. So there's a lot of ways the blood draw can go in a suboptimal way that might affect it too. But I think my general sense is that she's probably somewhere in the middle and the test is accurate to within 5 or 10% this way and 5 or 10% that way. Unfortunately, for people in this room, the tests that are for the rare factor disorders are often a little bit less accurate, and I heard somebody say consistent, than tests for more common disorders. If someone's going to get their blood counts checked. The labs do that 100 times a day, and they run quality assurance tests on that twice a day, and because that's the bread and butter. This test, they batch up all the samples and they run it once a week at the most. So it's hard to tweak that test and have enough patients that can donate blood to design the test and make sure the test is running in a high quality way. And to you, companies don't put a lot of money into making the reagents, and they don't have technicians that specifically service the factor 10 checking machine when they can service something that's checking the cholesterol level machine that goes through a lot more samples and is more profitable and that sort of thing. So I think it's a little bit of an unfortunate consequence of a test that is not quite as accurate as we would like it to be, and her real level lies probably somewhere in the middle with a margin of error around it. Yes, it's a great analogy. Mm-hmm. And different hospitals have different, or different labs have different reagents too, and sometimes the brand makes a difference. So, for example, for the PT, if you run it at your lab and you use reagent X, and you run it at your lab and you use reagent Y, the PT from the same sample might be 12.8 seconds in your lab and 14.7 seconds in your lab, and maybe those are both normal. So each lab that uses each brand of reagents puts that information into a calculator that was devised and spits out something called the INR, the International Normalized Ratio. So each company that makes a specific brand of reagents for testing has sort of a conversion factor. And that's so your lab's 12.8, I said, and yours is 13.9 or whatever, but they both are an INR of 1.1, which is normal. Okay, so I'm relieved, but otherwise. So that's a component too. My point is reagents and brands matter.
I have one right here.
Can you tell us about the mouthwash?
I probably should have had more of it after my coffee this morning, but I did find some mints. Are you talking about Amicar mouthwash? Yeah, so Amicar is the brand name for aminocaproic acid, which is similar to tranexamic acid or TXA, and is an antifibrinolytic. So that will slow the clot breakdown. It gets in between here and kind of strengthens the ring around the plasminogen creature's mouth, making it tougher to cut so you don't break down the clot as easily. So once you make a clot, you hang on to it for longer if you're using an antifibrinolytic like Amicar. There are little tablets you can take. They're real small and you have to take a bunch of them. There's an IV form, but there's also a 25% solution that I use for a lot of kids. So the idea is if you're bleeding, you bite your cheek or you get a tooth pulled out, I have you swish it around and you can swallow it. So it works topically too. If you're bleeding on your hand and it won't stop, you can put some on topically. We have people put it in their nose for nosebleeds. The pharmacy that I worked at the HTC where I worked in Colorado was developing a nasal spray, so you can spray it up into your nose. So it gets absorbed and works systemically kind of from the bottom, and then it works topically from the top. So you get kind of a double whammy. But so I use this for a lot of kids or people with nosebleeds, but you can swish it around in your mouth and then swallow it too. Oh yeah, you're welcome. That's a great one. Yeah, hi. Okay, thanks.
So when we look at, those of us who have more than one bleeding disorder without having a normal hemostatic baseline with other factor deficiencies to cause reduced clot initiation, reduced clot stabilization, and platelet adhesion, how do you, as a physician, know how it all works together, or do you just not? Is there an assay? Is there any kind of testing that you can go and say, okay, this patient has deficiencies in this,
Yeah.
this, and this? Is there anything you can run it through to measure what that coagulation cascade really looks like in that one individual?
Yes, that's a really good, interesting question about being able to step back and see the forest for the trees, in a sense. And I think the answer to your question is the global assays of hemostasis. And there are a few different ones of these, but rather than just checking every factor level, oh dear. Let me apologize to you guys for what you see over here on your left. That's a lot. No, so instead of just measuring factor levels, we can be able to, in a sense, put it all together by looking at global assays of hemostasis. There's one made in Germany called the ROTEM for rotational thromboelastometry, and there's one that is called a TEG, a thromboelastograph. There's what is called viscoelastic testing. And what that means, elastic is like stretching and viscosity is thickness. And so you're measuring kind of the thickness of the blood. And so this has replaced, I think I got talking about this, but I was talking about the bleeding time where you would cut someone and see how long it took to stop. That was a nice global assay, but you did have to cut someone. These assays instead, you can take someone's blood and put a small amount of it into a little cup. And then there's a pin in the cup. And the difference is with the ROTEM, I think the pin moves, and in the TEG, the cup moves. But the idea is that you put the blood in, you put a little thrombin in to make it start to clot, and then this pin is supposed to be moving in there, stirring, and like as you know, you stir milk for a little bit, and then it turns into maybe cream, and then goes to butter, and then it turns, so as you keep doing it, it's getting thicker and thicker, and just like in the PTT, this little ball that's moving back and forth will start to slow down and stop, and then you can measure the clotting time. In this sort of thing, as it gets thicker, the pin is not moving as easily, and the machine is able to sense and analyze the tension of that and can put it into a graph. And then there's different components of it. So you can measure how long it takes until something starts happening. And then once it starts happening, how quickly does it go to maximum potential? So you can measure that angle. And then how high is that maximum potential? How much stress is it feeling? So you can kind of measure things out like that. And based on different parts of it, you can see if the amplitude is not high enough, then maybe there's a platelet problem. If it's taking too long to get started, then maybe there's a factor deficiency. If the angle is not steep enough, then maybe, so you can kind of put it out. So that would be how I would answer. We look at how it all works together.
Okay.
We probably have time for one or two more questions.
I was going to say one or two because we are almost at the end. I have one here and one back here.
And I have one on here too, on
Okay.
Zoom.
I'll try to trim my answers so I don't want to hold up lunch.
Just a quick question. Have you had any history with patients with G6PD deficiency and factor V Leiden?
G6PD deficiency patients, yes. What was the last one? Factor V Leiden?
Yes.
Yes, so the G6PD deficiency, G6PD is an enzyme that is important in red blood cell health and metabolism. And the short answer is if you're missing that enzyme, then they don't process things as well. Certain chemicals like sulfa, chemicals that are in fava beans, for example, is a classic one, certain antibiotics. And so the red blood cells break down more easily. So that's not a disorder that causes more bleeding, but it can cause anemia, certainly because the red blood cells break down more easily. And factor V Leiden is a relatively common disorder that actually makes it easier to get a blood clot. And I have a whole thing on factor V Leiden that we could talk about maybe separately later. But essentially, they discovered it in Leiden, which is a city in the Netherlands, because they had a group of hemophilia patients, and one half of them bled a lot and one half of them didn't bleed so much, even though they had the same factor levels. And they said, why is that happening? And they did gene sequencing on both of them, and they found that these guys over here that didn't bleed a lot had a variant in their factor 5, and it led to factor 5 not turning off as quickly as it should. So it kept making more thrombin, which is good if you want to stop bleeding, but not as good if you want to stop clotting. So they found that it sort of balanced out the bleeding disorder a little bit and made it more mild. And they named it after the city where they discovered it. One in the back, and then we have one online.
Okay, it says, are there levels to factor 7 deficiency in the case of extreme and mild? And if they require a daily shot or infusion or some type of, to sustain them, excuse me.
Yes, I would say there are different levels of severity for all of these factors, but in particular, factor 7, which is one we see a little more often. Usually below about 3% is considered pretty severe, where somebody might need to take, I had a patient with a level of either 2 or 3%, and we had to give factor 7 doses once every day. If we gave it more often, then and he was diagnosed at birth with a big bleed in his brain, so he was hard to find a vein and give an injection to every day because he was a baby. So we had to put in a Metaport underneath his skin, which is a big catheter, and so if we infused that more than once a day, a blood clot would develop in the catheter because you're giving this activated factor 7, which turns into a clot very quickly. But if we didn't, then he would have bleeding from his GI tract. So that was more severe. Whereas there are people that have technically an abnormal factor 7 level of 48%, which we only found out because they had a long PT that the orthopedic surgeon checked to see if there was going to be any trouble before their ACL repair or whatever it was. And we would otherwise never have known, and they don't bleed. So it's probably, I would say, below 3% is severe, below 20% is moderate, and then below 50% is mild for factor 7. Okay, how about online?
Okay, it's a little long, so bear with me here, but some background. The patient has acquired 13, and they're in a state where there's only one site that can handle 13 testing. It says, what's your gut reaction to advice where I've had acquired deficiency in 2021 and had an activity less than 35%, but then for approximately the last 3 years or so have had normal levels right around 100%, so no major bleeding. But now I'm having trouble with bleeding and activity levels are still normal. Other factors have been checked. And factor 13 has been monitored approximately every month.
And it's still normal, it sounds like.
Yeah, being normal and normal, but now having trouble with bleeding again. Other factors are normal except elevated 8, they say.
Okay. Elevated 8, this is one that I see 8 levels go up in the setting of inflammation. So during an infection or after a trauma or during pregnancy, which I'm told is stressful. You know, the body, we've sort of evolved so that the people who are going to deliver a baby where there's a high risk of bleeding, the levels of factor 8, fibrinogen, von Willebrand factor, all those help you stop bleeding protein levels go up. So factor 8 is one of those, and that just might mean there is stress going on in the body of this individual and might be a direct result of that bleeding. So a point about congenital versus acquired. So congenital or inherited is a disorder you're born with, whereas acquired is something that comes on later in life. Usually the acquired deficiencies are related to an inhibitory antibody. So this patient has made antibodies from their immune system in response to something, an infection or a malignancy or an autoimmune disorder where the immune system is kind of acting indiscriminately and is kind of turned up too high and has made antibodies against factor 13 for some reason and has destroyed the levels of factor 13, even though they're making it, they're destroying it. So they have a functional deficiency still. And it sounds like that has resolved, which I would expect because after some time with or without immune modulation therapy, eventually the antibodies wear off, which is why we need to get a booster for some of our vaccines over time because those antibodies will wear off. So it sounds like that is what's happened there. And it sounds like the factor 13 is in good shape and the factor 8 level is high, which would not be associated with bleeding. If anything, if it gets too high, it might be associated with pathologic blood clots. But it makes it seem like there's something else going on. And if this person's immune system started destroying factor 13 once, I would be suspicious that it might be destroying some other factors. So checking those other factors was a good idea, but it could be that they have started maybe von Willebrand is the target of an inhibitory antibody, or there's a platelet problem. Unrelated to any of these factor deficiencies, there are immune-mediated platelet problems like ITP that they're maybe talking about next door, immune thrombocytopenic purpura, where the immune system just destroys platelets. Factor levels are all fine. Platelets are being made appropriately. They're just being destroyed. And so there's a number of things that could be happening there. Or if all of a sudden there is, if it's period bleeding, then maybe there is, or bleeding outside of a period, maybe it's an anatomic problem like endometriosis or fibroids or something like that. Or if it's just nosebleeds, maybe there has been a nose problem and it's not bleeding disorder related. So there could be a number of things there. Factor 13 is tough to measure because, even at our big, busy coag lab, we still send it out, I think, to either Mayo Clinic or the AARUP lab in Salt Lake City. So there's not many places around the country even that do factor 13 testing. That's a hard one to monitor, but if it sounds like that level is going well, then we need to look at some other things, whether it's an anatomic problem or a non-factor problem like a platelet problem or a von Willebrand problem or something like that would be my advice to that person.